Hello, I'm Dr. Sonia Anand, and I'm pleased to participate in this meeting presenting on culturally sensitive heart failure care. And I'll begin with a case. This gentleman was a patient I saw in the thrombosis clinic, a 69-year-old South Asian gentleman who had suffered a STEMI and associated heart failure and has an ejection fraction of 30%. He was found at the follow-up heart function clinic to have an apical left ventricular thrombus, and he was referred to me at the thrombosis clinic for consideration of anticoagulation. And on that visit, he was accompanied by his daughter, and it was difficult for him to communicate in English, and therefore his daughter translated the interaction. During the interaction, it was challenging, not only due to the language barrier, but my patient was relatively despondent and uninterested in the interaction and physical exam plus recommendations. So we'll come back to this case toward the end. When we think about our practice in Ontario, and in particular in the Greater Toronto area, we know that a large proportion, upwards of 25% of Ontarians, come from an immigrant or non-white ethnic population. And if you look more closely in Toronto, you know from your own practice, but you can see here that there are a large number of non-white ethnic groups, and these people may become your patients. So when we think of culturally sensitive heart failure care, we have to think broadly. And in fact, when we think of Canada and the most populous non-white ethnic groups, number one would be people of South Asian origin, those originating from the Indian subcontinent. Second would be people of Chinese origin. However, we also have a large and increasing number of new Canadians from Southeast Asian backgrounds. This could be Vietnam, Laos, and we also can add to that Black Canadians and Indigenous people. So we have quite a large patient population. Each patient population from a different ethnic group has different cultural considerations that we should take into account as healthcare practitioners. Now, in 2010, the Canadian Cardiovascular Society heart failure guidelines did focus on ethnic minorities, and they prioritize South Asians, Chinese, Black individuals, and Indigenous people. And essentially, the recommendations can apply to many other ethnic racial groups. Number one, healthcare providers should consider the prevalence and etiologic factors of heart failure, language, ethnoculture, and social values, as well as diagnostic patterns and the potential barriers to healthcare that are specific to their patients with heart failures from an ethnic minority. And this was a Class 1 Level C recommendation at that time. They go on to say that practical tips include family and social values within the ethnocultural background underlie a patient's attitudes and beliefs towards health and disease. You, as a healthcare practitioner, should ensure proper language translation and include family members in the planning. And of course, respecting local traditions and be careful not to impose the professional's own values. So I think these are recommendations and tips that we can extend beyond the most common or prevalent ethnocultural groups to all of our diverse patients. Now, when we look at some of the literature where mixed methods research has been applied to try and dig deeper into understanding specific ethnic groups specifically related to heart failure, this study by Dixon and colleagues from the United States focused on African Americans with heart failure. And through qualitative interviews, we're able to center the patient within the patient's context and try to understand the factors that influenced self-care, which is such a crucial component of heart failure management, as you well know. And what they demonstrate are, first and foremost, cultural beliefs are strongly influential in terms of self-care. For example, some participants believe that developing heart failure was part of their destiny or fate. And a direct quote is, "All my people have bad hearts." Others attributed their heart failure to stress, and this influenced their daily self-care. Spirituality was also linked to their self-care, and in one case, the patient stated that the doctor may order medications to improve my health, but I pray for my health. So understanding the cultural beliefs are important when you are describing self-care plans. Cultural beliefs were also found to affect and influence drug adherence. So when we see these patients and they leave our clinics on 5 to 8 different medications, adherence is strongly influenced by an individual's cultural beliefs around medication with respect to trust in the healthcare provider and system, as well as things such as the nuclear family and extended families' beliefs. Cultural beliefs also influence food choices, which in the case of heart failure is particularly important when we are giving advice such as sodium restrictions. One of the strongest factors that was highly correlated with self-care was the patient's social supports and social norms and values. And picture the case of the gentleman I presented within his nuclear family, having the strong social support of his daughter is crucial, of his wife is crucial, and the social norms are such that if the food for our patient is prepared by his wife, then our recommendations in terms of sodium restriction will not be implemented unless she is involved in the care plan. And this could be via a handout to her daughter, to the patient's wife, because we often don't have all family members there with us in clinic. But keep this in mind that the individual's social supports are so crucial. And then social norms are important too. So if an individual does not want to insult the cook of a meal, they will not mention, "I'm sorry, I can't eat this food, it has too much sodium," or "I'm sorry, I am on a special diet." So although we do our best with medication advice, with lifestyle advice, we cannot always break through some of the social norms and conventions. And here are some more examples from that study. As I described, individuals describing, in the case of the 73-year-old man, described his challenge to following a low-salt diet as, "In my culture, women do the cooking. I have a daughter. She prepares the meals for me, and I eat what she prepares." And a final example is that of when an individual doesn't have social supports. "I used to go to the center, hang out, talk, play chess. I have a lot of friends, but now since the heart failure, I can't make it. I'm too tired, and I don't want them to see me like this." So this gives you a sense of trying to place your patient in their particular context. Now, having conducted ethnic specific research in cardiovascular disease, specifically MI and type 2 diabetes for 2 decades. What I think is the optimal approach is this mixed methods approach of qualitative together with quantitative data. Uh, One question which is very reasonable is, do we need to do studies in each ethnic group? As I showed you, there are many different ethnicities within Toronto and Ontario and Canada. Do we need a separate body of literature for each ethnic group? And I would say that if we were looking towards an ethnicity cookbook for research, I think that we do need our etiologic studies overall to help us understand causes of diseases such as heart failure. We do need the large randomized trials to inform us as to the best medical therapy. We do not need to repeat these large and broad set of etiologic as well as RCTs in every ethnic group. However, there are some types of studies that are quite informative within ethnic populations, and this can include smaller observational studies to understand the context of our patients, the reasons they do or do not seek healthcare. We can conduct some of these studies using administrative databases if we can link them to self-reported ethnicity. The qualitative studies are so important, informative to help us understand the context in which patients find themselves, so that we can take this evidence-based medicine approach, combine it with an understanding of the context, and then try and come up with some innovative and sometimes novel ways of implementing the evidence. And this is where, in the area of knowledge translation or implementation science, randomized trials of types of modalities, practices, or programs are needed within high-risk ethnic populations where the simple prescription of medications has not led to an improvement in their health. And an example I'd like to share would be this type of approach within an African-American population from the United States around the issue of hypertension. And many of you know that hypertension is a significant risk factor for stroke and cardiovascular disease, and is particularly prevalent and poorly controlled amongst African Americans. So Ron Victor and colleagues understood the context in which Black men in particular may be in a position to receive health advice from a trusted member of their community. And this, in fact, was in the barber shop. And they conducted a study by which the barber actually measured the blood pressure during a barber visit and followed an algorithm such that if the client was found to be hypertensive, they would call in the local pharmacist who would follow a predefined algorithm to get the patient started on medication. And you can see here that the barbershop intervention, when we look at baseline in blue and end of study in orange, was associated with a 22 millimeter of mercury reduction in blood pressure compared to the control population, which is essentially usual care, where the blood pressure started in the hypertensive range and did not decrease substantially. So with the barbershop style intervention, 64% of this population in the intervention group reached the target blood pressure versus only 12% in the control. So this is an excellent example of taking the evidence base, putting it together with the context, and coming up with a successful intervention that will treat a very important risk factor for stroke, MI, and heart failure. Now back to the case. When we came back to the patient I presented at the beginning, at the 3-month visit, the patient was reassessed. And prior to leaving the clinic on the first time, because of the language barrier, the daughter was instructed about the medications for her father, about the timing, the side effects, and including the use of warfarin and monitoring with INRs, which can be quite challenging. The handout about self-monitoring of sodium intake and daily weights was given. And because her father appeared to be not very engaged in the appointment, his daughter was instructed to take her father to the family doctor to see about depression. So when they returned at the 3-month visit, the 6-month visit, the daughter reported her father was doing better and had been started on an antidepressive medication. The time in the therapeutic range for warfarin was not optimal, only at 50%, but on repeat echo, the LV thrombus had resolved and the patient could be transitioned to a DOAC because he had atrial fib. And in terms of other reports, his daughter reported the father was eating his usual meals prepared by the wife, but there had been no sodium change. So this is an example of, 2/3 successful in terms of his overall case. He was doing better. He did come back to clinic. He was on most of the medications and had improved his mood in the area. To add improvement to would be with respect to his dietary practices. Again, perhaps bringing or asking his wife to come in or communicating strongly through the daughter about sodium reduction. So just to conclude, why should we tailor heart failure care to different cultural groups? It increases the uptake of evidence-based RCT-guided recommendations. It can lead to improved self-monitoring and care. It is associated with higher adherence to medical therapy and dietary recommendations, and ultimately can serve to reduce clinic visits, hospitalization, and death for our patients from diverse backgrounds. So I know you'll be hearing from Dr. Jeff Redding, who will add to this approach with an Indigenous lens. And I hope you find both of these presentations useful as you go forward with heart failure care. Thank you very much and have a great day.